talked something about the saturation gap. We have a saturation gap with methemoglobinemia as well. So what is the difference between a saturation gap with the carbon monoxide and the saturation gap you see with methemoglobinemia?
I'm not sure, sir. I know the answer to that.
Yeah, somebody has answered it actually in the chat. Basically, what
The
happens in
saturation will be low. I mean, you are not going to get a raised. Your sp2 will remain low despite oxygen supplementation in a methemoglobinemia patient.
So basically, saturation gap is basically a difference between your SpO2 and your the SaO2, the thing that you're seeing on the blood gas. So in methemoglobin, what happens is that the SpO2 is low, but the SaO2 is actually going to be high, because most of the time you see this low SpO2 and start the patient on oxygen. So it will be more than 100, and whereas the SpO2 will be like 85 or something. So that is a pretty good sign that the patient is actually having methemoglobinemia. But what is happening in carbon monoxide?
Carbon monoxide saturation is again going to be high only, sir. Just that the patient is going to be more sicker because of the less oxygen availability. I'm not sure. Like, what is it that you specifically want to ask?
Yeah, well, it is going to be false. The SpO2 is going to be falsely elevated.
Falsely elevated.
Yeah. So the problem with that is that clinically it's going to be very difficult to actually understand that you are actually seeing a gap, because if you're doing an ABG and
you may
see
mistake it that you are taking a femoral sample as well. If you are taking a femoral
you'll
sample,
think that the immediate reaction is that, okay,
I've taken a femoral sample.
I poked the vein inside of the artery. So detecting a saturation gap with the carbon monoxide worsening is a little bit more difficult, practically speaking.